Afternoon, everyone. It's 12 o'clock. Thank you for joining the first of our Advanced Care Learning Community webinar series. For those of you who might be joining for the first time, I'll share a little bit more about who OPCA is, what this learning community is about. And for those of you who have been here before and have joined us in this past, thank you for coming back. We're really excited to kick off this webinar series at OPCA. We've been learning and hearing from all of you, our FQHC members, about areas of needs and the need for more peer-to-peer connection and application of practical strategies. We know workforce and workforce resilience is not that it's a hot topic, but it's a huge need. And we also know that many of you are involved in value-based care models, really looking at comprehensive care through a team-based lens. And we know that with those kinds of models comes a lot of complexities around, again, administration, billing, communication, teamwork, as we all try to do the best and provide whole person, patient-centered care for patients. So again, welcome to our first webinar of this webinar series on the topic Beyond Integration and Supporting Workforce Resiliency and Team-Based Models. Today, for our kickoff webinar, we will be discussing practical strategies for providers of all different domains and disciplines on navigating patients' social needs and responsibilities. We will be recording this webinar, but we will be either pausing or editing out any peer-to-peer conversation, but would love to still share some of those practical strategies with your peers who are not here today. And we will go ahead and just get started to make sure that you all have a little bit of time at the end to transition into your next meetings. And I should say, my name is Stephanie Castaño. I am the programs director at the Oregon Primary Care Association. I've been here for, I think, a little bit over 10 years at this point. So it's been a pleasure to be able to serve FQHCs and again, to engage folks in different ways and in the way that we are transforming care for Oregon patients. Would love to know a little bit about who is on the call today. If you can go ahead and take a moment to share in the chat your name, your pronouns, the role that you have, and the organization. I think that's always helpful to have a little bit of context of who's in the room, and if there's someone or someone with a liked role that you want to reach out to, feel free to use the chat to connect with one another. Again, we are all peers from FQHCs in the space. So please feel free to introduce yourself and then feel free to connect with one another in the chat. Just a little bit about what we have planned today. We'll do a quick introduction. Again, a little quick about OPCA and the Advanced Care Learning Community. We have a guest presenter, Dr. Amy, who will be sharing some content with you and engaging in conversation. And then we'll quickly we'll ask you for some feedback. Again, this is a webinar series, and we want to make sure that we're creating a space where you can share what topics of focus are most important to you. So we'll have a moment to hear from you, and then we'll just do a quick wrap up. So that's the plan for today. And again, if you are new to this space, just a quick disclaimer, we are also HRSA funded at the Oregon Primary Care Association. So just please know that this is where our funding comes from and how we develop our content and bring you all together. We are the association for all of the federally qualified health centers of Oregon. And so together we provide training and technical assistance and advocacy with your support and on your behalf. You can see some of our OPCA staff members here at the Capitol advocating for FQHCs and the needs of patients. And we have an OPCA website if you want to learn more about us, or you can reach out. But just a little bit about this as a space, and we're an organization that really serves you all. So again, thank you so much for joining us today. Quickly about the Advanced Care Learning Community. Again, if you've been a part of OPCA or have been connected for some time, you may have heard of us, but if not, this is a space that was created back in like 2013, 2014 for clinics who are part of our APCM program to practice and brainstorm and be creative around what kind of care models do we want in a value-based care environment with new value-based payments. So we've continued to create this space to be able to talk about those complexities, try new things, share work, share challenges. And so this is just another iteration of that. And again, we will be talking a little bit about team-based care and how to support the workforce and again, a diverse care team. So again, just a little bit about us. If you'd like more information, please, again, feel free to chat me. We also have Tori Baldwin, our APCM manager here. So for any of those APCM clinics, please feel free to reach out directly to Tori or again, any of our OPC staff. We're happy to connect you. And again, just a little bit about our topic, which I've shared, but I've added this for context. But let's go ahead and move on to, I think, what everyone is here for. To hear from our subject matter expert or guest speaker, Dr. Amy, who will be sharing with you a little bit about some practical strategies for navigating patient social needs and responsibilities. Again, I know at clinics, this is a space that you are, again, collecting the needs of patients and trying to navigate what social services or social care they need, which we know can add a lot to your plate and can add stress and, again, thinking about what you might be able to accomplish. So Dr. Amy, if you'd like to introduce yourself to folks and share a little bit about yourself, we'd love to meet you.
Wonderful. Thanks, Stephanie and Joanna. Thanks for having me here today. And it's great to meet all of you or e-meet you virtually as it is. I can share screen, Stephanie, if you want to swap out, that would be great. I'll probably do a bit of screen sharing and pulling my screens down because I think more than anything right now, we need community and connection and some togetherness. So I'm also just going to be that person for a minute and encourage you, if you'd like to and you feel comfortable, to turn on your cameras so that it feels like we're in community together. Also, otherwise, I feel like that awkward algebra teacher during the pandemic where I'm just talking at little boxes on the screen. So if you're so inclined, I would love to see your faces. I have a lot that I can share today, and I have slides that are prepared. And I feel like the most important thing is conversation. And so your agenda supersedes mine. And so if there are questions that come up as I'm talking about various things and you would like to interrupt or raise your virtual hand or pop something in the chat box, I would love to hear from you. So without further ado, I will share my slides here and I will send all of these to Stephanie as well so that she can send them out to all of you so that you have access to this information as well. While I appreciate the formal introduction in this space of Zoom connectedness, I feel like if we have a little bit more human beingness, it helps us feel connected. And I'm also just trying to model for all of you what I think we need more of in primary care. So as Stephanie mentioned, I am a licensed psychologist. I'm a consultant and a trainer. I'm a recovering behavioral health consultant, and I see that there are a couple of you on this call as well. So I was in primary care and pediatrics as a BHC for several years. I'm an author with the American Academy of Pediatrics, and so that book was given birth to this year. I'm also a coffee and wine lover. I live in the Wine Valley over here right at the cusp of Washington and Yamhill County. And I'm a murder mystery lover. So if any of you have good recommendations, you can pop those in the chat box as well. And most importantly, probably like many of you, I hold roles that are near and dear to my heart. I'm a mom of those two kiddos who are there. My daughter's at Oregon State, go Beavs, and my son is a senior graduating this year from Sherwood High School. And I'm a wife and a daughter and a friend, and like all of you, I'm a helper. When I'm not doing these Zoom workshops, I'm out doing keynotes, and I also have what are called connected collabs, where I meet in monthly spaces with often healthcare providers around burnout and workforce vitality and workforce wellness. So I feel like I could talk to you just forever about these topics. And so it was hard to choose just a few things to highlight today. So certainly, like I mentioned, ask questions. I hope you get your cup filled up a little bit today. I hope that we can have a conversation about how to better understand current complexities of both patients and staff in primary care. I'm going to give you a few highlights around boundaries and how we can integrate those, and then some tools that might go along with that, both personally and professionally.
Dr. Amy, this is Stephanie. Would you like me to go ahead and launch that poll just
Oh,
to see what
sure.
folks? Yeah. All
Yeah,
right,
that would be
folks.
great. Thank you.
Great, thank you. And yeah, for folks who are on the call, you'll see that we've posted a question here in the polls, if you don't mind taking a second. Again, we'd just love to learn what you're hoping to take away from today's webinar. I know our time is short, but it's always great to get some real-time feedback from all of you. So we're going to go ahead and leave that open for a minute, and then Dr. Amy, you're welcome to continue then.
Thank you. Let me know when you feel like you have a collective mass of answers in. I want to just start first with understanding complexity and what I think folks are facing in primary care right now. This is a horrible title, but I didn't get to name this particular title or this model. It's called the Phases of Disaster. It comes out of UCSF Medical School. But basically, it provides us common language about what we can anticipate when we go through collective stressors. And that might be a collective stressor like a global pandemic. It might be something nationwide, like an election or insurrection of election. It might be something that's happening in our state or even in your communities or counties, like a fire or natural disaster, or something as local as something like a school shooting. But what it does is it gives us collective words and common language so that not only do we as providers feel like we have language, but it also helps our patients and staff greater understand a little bit better what we're going through and also what to anticipate. I think unfortunately right now, one of the things that are happening is this term post-pandemic. And I think a lot of you would agree that it doesn't feel post-pandemic, that we are continuing to see behaviors and reaction that very much feel during pandemic or pandemic related. But if you look at this, it kind of gives us this opportunity to understand what's been going on. If you can believe it, we're past year 4 of an anniversary of the pandemic. But hopefully will help understand the complexity of patients and staff in your clinic. So you can see here, do y'all remember way back to 2020, at the beginning of that year when there was this warning, right, in Wuhan, and there was a threat of potential impact, and oh, but that virus was going to stay in China, and then there was a moment of impact. And all of us can remember individually where we were during that moment of impact. I was personally talking with a large school district about trauma-informed care, and all of a sudden all their phones started going off. And they said to me, you know, Dr. Amy, we need to know how to tell thousands of families in a trauma responsive way that they're not coming back to school. I was working yesterday with a group of physicians around this common language, and one of them said that she was actually at a conference in California with a friend of hers who is an infectious disease expert. And so he got pinged for his expert knowledge around the first case that was happening in the Pacific Northwest. So I'm sure all of you remember that moment of impact. And then very quickly, right, we move into that heroic honeymoon phase, where we gather together as a community, and certainly we did as a country, and we were banging pots and pans for healthcare heroes. And then there were periods of disillusionment, and I think there still are. And that's what I want to highlight when we're thinking about complexity and primary care. That there continue to be disillusionments around healthcare systems, triggering events in communities. Maybe you could, if you feel comfortable, just pop in the chat box. I would love to see events that have felt like triggering events that kind of perpetuate these feelings of disillusionment during pandemic grief that maybe were happening in your own counties, in your own areas or regions, or specifically to the patient population that you most affect. I think about like the fires that were happening in the Valley and the fires that happened down in Jackson and Josephine County. That's an example of a triggering event. Elections, of course. Things that often get also mentioned to me from primary care is just the profound effect of substance use and abuse that has gone up, as well as the fentanyl crisis. So just take a moment and pop in the chat box when you think about what we would refer to as compounding stressors. What are things that you think of either in your communities? Oh, absolutely, Nicole. The election, right? We're going through an election cycle. I think that that triggers a lot of folks in communities. If there are specific things, I don't want to assume, but if there are specific things that has created that activation, feel free to pop that in the chat too. Yes, Brianna, this space of just lack of access to primary care, really needing to have folks be able to access care. And then I see Bill put in here, I'm still sometimes shaken up and frustrated when a patient gets into an exam room that's acutely sick, but hadn't informed the front desk. Yeah. Yeah. I mean, those are all examples, both individually and geographically, right? Things that are continuing to affect us. That's why I'm really careful to not say post-pandemic. I mean, to Bill's point, right? It still feels like, wait a second, you're ill. You could make me sick too. Yeah, Tony, thank you. Often, I think I saw earlier, Tony, that you're in Multnomah County, whether I'm at a Multnomah County or area where there's a large homeless population, it just can feel scary or intimidating, but also just very sad about the current state of things. Oh, Maeve, yes. One of my best friends is a pharmacist, and she is grieved every day by the medications shortages. Yep, lack of resources, vaccine shortages, yes. So we're still in this space, even 4 years later. You can see from your colleagues' comments in the chat box of what we call working through grief, coming to terms with things that have faced us during the pandemic and continue to. So when it comes to patients and staff, things feel really complex right now. Some of those things you mentioned in the chat, and please feel free to continue to share in the chat. Yeah, I mean, Tony just named another one, staffing shortages. By the end of 2020, millions of female identifying folks had left the workforce. That's going to affect medical systems, right? It's going to affect people who often hold those roles. So other compounding stressors, some of you mentioned the housing insecurities, political upheavals, job and food insecurities, and just less resources and lack of mental health support. I did a debrief with a community mental health center, gosh, more than a year ago now, for their front office staff, not even for their mental health providers, but their front office staff who were being activated on a daily basis by not being able to get people in soon enough or at all for mental health services. We know that marginalized and under-resourced communities have been significantly more affected on top of going through this global pandemic. And I think the complexity that create what we call these compounding stressors is that it's not as if in healthcare buckets were feeling full and overflowing already. There's been a lot of vaccine hesitancy, shifting to online meetings, safety. Several of you just mentioned COVID safety, COVID precaution, vaccines, masking, trying to do telehealth on Zoom, and then navigating medical misinformation and COVID restrictions. And I think the other thing that I want to name for all of us is our own personal losses, including isolation. We're really meant to be in community. And so when I meet with medical groups in person or virtually like this, I just see such a need right now for us to be together, for us to be in community, to be able to share collectively some of those compounding stressors that everybody is going through, and to name them. And when people are saying things like post-pandemic and moving on or moving forward, I think it can feel really minimizing and devaluing of folks' experiences. And what I would say is, if I just kind of get on my Dr. Amy soapbox for a moment, we mistook safety with social isolation, and we were sending messaging to be away from people. Some of the most creative and beautiful stories that I have heard over the last 4.5 years now are folks who figured out ways to be social and connected and safe physically as well. And so I think, especially if you have kids and young adults in your offices that you're seeing, we're going to see the effects of the pandemic on their behaviors for likely the next decade or so. Young adults and those of us kind of going back into work, virtual, moving from virtual spaces, et cetera. Just reconciling staffing shortages. There's a lot of clinics, and maybe yours today are some of them, where part of your staff are still remote. And that can hurt the ability to feel connected as a clinic and kind of in person. And so we have to be, extra creative around that. But I want to just continue to name that for your staff, that those effects of not being connected and being socially isolated have complicated things. And so what I hear from folks is it's really increased behavioral complexity, both in patients and in your staff and in each other. So I want to just validate this is what I've been hearing for the past few years as I travel around the state and around the country doing speaking. The behavior that we see is more complex than ever. I don't know that there are any straightforward visits that are happening right now in primary care. There's more trauma that's manifesting as aggression and withdrawal, whether that's somebody yelling at your front office person, or angry, or just reporting aggression that's coming up, or withdrawal that's coming up outside of the visit. We see more aggressive behavior, and we see more behaviors cropping up in younger kids. So for those of you that, are also seeing pediatric patients, younger kids are having really tough behavior. Some that I haven't seen in as much of as I have in the recent years. Obviously, much more depression and anxiety across all ages. And my friends and colleagues, like all of you, are just feeling really maxed out. Not feeling like there's enough support due to staffing shortages, et cetera. And just for the first time, I'm hearing people say, I don't know if I'm making a difference. Is what I'm doing more than just a drop in the bucket? So if that is you, if that is how you're feeling, you are certainly not alone in that. That's how many of colleagues and providers are feeling that I talk with in many different spaces. So I want to just pause for a minute and see faces that I can see. Does that list seem pretty validating to all of you? Yeah. So I want to just give you one tool today that you can use or take back to staff and other colleagues, and that is the concept of duality. And so let me just show you that picture one more time, and then I'll pull down my screen again so that I can see all of your faces. You'll see on the left-hand side of your screen, these boys, right? They look confident and strong, like, I got this. And on the right-hand side of the screen, a little girl who maybe not so much, right? I'm feeling kind of overwhelmed. One of the first things I want to offer when we think about wellness or workforce wellness is that being well doesn't mean always being okay, and that it's okay to not be okay. And the duality of feeling strong and confident and feeling like it's too much is absolutely the space that we need to validate for ourselves and for staff, and also for the patients that you're seeing. So let me give you an example. So a duality is two sentences that seem like they might not go together, but actually do. And the more we can embrace duality, as professionals, the more we kind of can embrace our own humanity. So I'll give you a couple of examples. I'll give you a personal example and a professional example, and maybe there's folks that want to take a try at this yourselves, okay? Either in the chat, or if you're brave enough, you can unmute and share. So duality. I'm the oldest of 5 kids. I love being a big sister. And sometimes my siblings really annoy me and get under my skin. Both are true. Just because they sometimes annoy me or I feel like they drive me bananas does not mean that I don't love them. And just because I love them doesn't mean they sometimes don't get under my skin. So that's a personal example. I'll give you a professional example. I love being a psychologist. It is my life's work. I love connecting with people. I love having open, honest conversations. And being a helper the last 4 years has been exhausting. So I open this up to all of you. Anybody have an example of a duality that they have experienced either very recently or even a little bit more remotely? I know you're looking for your unmute button. It's not working. Well, you can type it in the chat if you're able to. Maeve, do you want to unmute and share, or would you rather me read your comment aloud? I'll start. Okay, no worries. Maeve said, I love being a primary care provider for LGBT clients, and I feel overwhelmed most days. Lindsay said, I love the place I work, and sometimes the pace and demands are too much. Yes, both are true. Again, the goal with utilizing duality and this tool is so that we can feel a bit more humanized and give each other a little bit more compassion in these spaces. I think otherwise what happens, and I'll pick on Maeve and Lindsay since they put comments in the chat box, is like, if I run into Lindsay at my place of work and she seems like, oh, this is kind of going too fast today and the demands are a lot, then I'm like, oh, you must not like working here. Aren't you committed to this profession? Don't you like being in primary care? And we start to make character judgments about one another instead of saying, yeah, the pace is too much sometimes, right? The demands are too high. Gosh, I don't know, Maeve, don't choose such a tough population to work with if it's, feeling overwhelming for you. But actually both can be true. You can feel overwhelmed and really dedicated to your patient population, and it can feel demanding. Bill, do you want to unmute and share, or would you rather I read aloud?
Sure. I appreciate the importance of meeting patients where they're at and offering them every service I can, and I feel sometimes frustrated that patients don't seem to take more agency for their health outcomes.
Mm-hmm. Both are true. Absolutely. And I missed Jen. Jen, do you want to share? I'll read aloud for folks that don't feel as uncomfortable or maybe don't have access to a mic. Being an LCSW, the day-to-day is grueling and the big picture is beautiful and powerful. Yes, both are true. Absolutely. Catherine, do you want to share? Nice to see you, by the way, Catherine.
Good to see you too. I love that in my current employer, I am able to be the manager of my team and also still continue patient care. It is really cool. And I don't feel like I have enough time in the day to do both patient care and be a manager.
Yes. Yes. Absolutely. Brianna, you had your virtual hand raised. Do you want to unmute?
Yeah, it's not weird. This is what we're talking about, I guess. From staff continuously are like, I can't do all this. It's too much. It's too much. And then an hour later or 30 seconds later, hey, we should do that. Like in direct conflict with each other. And I'm like, how do I, like, I need an hour for all of my appointments, and then turning around and going, we have a lot of no-shows. So why don't we think about overbooking?
Mhm,
Like for a
mhm.
tangible, and I'm like, it's hard to
Here's
like
I love that, Brianna.
navigate that.
Yes, and here's what I'm offering to all of you today. Look at all the hearts popping up in the validation in the chat box. Here's what I'm offering to you. Both can be true, right? To be able to look at your colleagues and staff, and if you're in a position of management, to be able to say, absolutely, this is exhausting. And I wish for many patients we had an hour, and sometimes it's just like we have to clip along at a different pace, right? Both can be true. And I think what you can offer someone with duality is just humanizing their experience. Jamie, do you want to unmute and share? No, thanks. Okay. Thanks for sharing. It says, I love being a caretaker and a fixer most days, especially this year. I feel as if I'm barely surviving. Yes, both are true. And Jen, you are speaking to the mom hearts of every caregiver on this call. I love being a mom. I love my son, and middle school years are challenging. All I can say to you, Jen, is I have a senior and a college student, and this too shall pass. And it will just become challenging in another way. So yeah, this is really amazing to hear. And I hope you can kind of feel the validation in the room when we begin to say, things are really hard right now. And I love what I do. And some days I want to quit. And I love my patients, right? There's so many ands. And what happens is we get into this space of mutual exclusivity, and then we don't allow ourselves to just not like our jobs sometimes, and then love it the next moment, and then want all the time, and then hate what we do. And when we begin to embrace those intersections, it allows us to stay in that space a little bit more and be compassionate with ourselves and other people as well. So that's a first tool that I hope is helpful for all of you. I also want to just talk a little bit about boundaries and the way I think about boundaries and teach boundaries that might just give you a fresh perspective when you think about care that you're providing, and integrative care in primary care spaces. So sometimes we think that boundaries are like a line in the sand, right? We will not do this. We will not pass go. If you cross this line, we are done. But in actuality, boundaries are unique, and they are self-determined by each of us. And they're actually a way of staying in a relationship. And I want you to think about relationship might mean with yourself, with a colleague, with your clinic, with your organization, but it's a way of staying in relationship. We set a boundary because the assumption is, I want to be in this with you. And I'll give you an example here in just a moment. It's scary for some people and welcomed by others, and boundaries are not implicit. They take time to unfold, to kind of figure out where we are and what season of our life that we're in. If you can't read the little cartoon on the left-hand side, this is from Molly Davis, and she has this little blue person, and it says, here, take this. This is what you get when you don't do what I want. And the little yellow person's like, yeah, no, thanks. That's your stuff. You can keep that. And it's just a pile of guilt and shame. And I know, this morning I host a weekly call called Physicians Anonymous, which is to prevent physician burnout and suicide. And every week I hear the amount of guilt and shame that sits in the laps of all of you, not just physicians, but any kind of provider that you are in healthcare, just feeling like the need to help and do more and take on more and wear multiple hats. And so it becomes really important to think about boundaries. What is a boundary? Like I said before, a boundary can be personal, it can be professional, it can be systemic. It is necessary though. And I'll explain why here in just a second. You uniquely determine your boundary. And boundaries essentially tell someone what's okay and what's not okay. So let me give you an example. I don't know about all of you, but in my family, There's always like awkward moments at family gatherings, especially around the holidays that are coming up. And so starting to set some boundaries becomes somewhat important. So I'll use a personal example. I won't say we all, in my family, we have an Uncle Bob, we'll call him, who tends to over imbibe during the holidays. And so I have to set a boundary. I want to be in relationship with my Uncle Bob, by the way. He's amazing. I want to be around my family. I want to be around my kids. But I don't like it when he drinks too much around them. And so the assumption when we create a boundary is, I want to be in a relationship with you. So I have to be able to say things to Uncle Bob like, Uncle Bob, come, please celebrate the next holiday with us. I want you to be there. My kids think you're hysterical. And if you choose to drink too much, we will order an Uber for you so you can go home safely. That's a boundary. It assumes I want to be in relationship with him. It's unique. It's self-determined by me. Uncle Bob gets to choose for himself what he does. Boundaries are hard to begin to think about and practice. And there are lots of opportunities to create them, as you know, in primary care, with colleagues, with patients, with teams, with ourselves. And they manifest through collegial discord at times, business versus personal relationships with our colleagues, tough patients, tough families, or expectations about our workload or deadline. And I want us to think for just a moment, and then I'd love to have a conversation about there's this continuum of boundaries in healthcare where it feels like we're either completely boundaried or completely boundaryless. And I want you to all think for just a moment where you're at on this continuum. But the unwritten curriculum of healthcare is that if we're completely boundaried, we're the consummate professional, right? We always have the answers. We're very stoic, removed from our patients, self-sacrifice. Patients are the primary focus, and identity, whoever we are in that space, nurse practitioner, community health worker, BHC, physician, provider, is everything. On the other end of that continuum is that when we're boundaryless, we're doing EHR, right? It's called pajama time. Not taking vacation, missing out on celebrations, taking extra call or extra clinic or vaccine clinics that are coming up this time of year, and being a helper for all. There are costs to this. When we're too boundaried, we're disconnected from each other. We're labeled like a healthcare hero, which makes us unrelatable and not humanized. And when we're boundaryless, we are at risk for suicide, burnout, and leaving the profession. Prentice Hemphill, one of my favorite quotes around boundaries. Boundaries is the distance at which I can love you and me simultaneously. I can love my job and take care of me. I can be with this organization and integrate things that I need to do for myself personally. So a boundary is defining two truths. That's why we started with dualities. What's okay and what's not okay. With the assumption I want to stay in relationship with you, right? So when I show up to large organizations to do consultation around workforce wellness, the first thing I say is, I assume you want to be here. Or I assume at least you have to be here, even if it's something as straightforward as a paycheck, right? And so let's figure out what feels okay and what doesn't feel okay for you. And holding those two truths. So how do we have these tough conversations in primary care so that we can feel well ourselves? Ooh, Bill's already putting some in the chat. Yeah, he said, a key boundary I created for myself is learning that my ability to see patients in 20 years is dependent on taking a lunch break. Oh my gosh, it's as if you were reading my mind. I'm going to give you an example of that in just a moment. And Bill might be able to model it better than any of us. But I think one thing I just want to say, right? If you're in this space, you are naturally a helper and a healer, right? And a lot of us resist giving feedback about boundaries or where our limits are because we're worried about responses either from our organization or our team member or colleague, like, oh my gosh, Amy's not very committed. She doesn't work through lunch every day, or she's, leaving charts that she has to come back to the next day. She must not really be committed to, her job or her patients or whatnot. And it's also hard when it feels subjective. Right? My boundary right now is dependent on the season in my life and my emotional capacity. And that might change next week or next month or in a couple of years. I think it's also hard. It feels uncomfortable because we're kind of doing something that's subjective or providing an opinion. And so whenever possible, we want to talk about boundaries in person and be specific about our concerns. So here's just another little tool for you. I call it the 5 C's of communication when we're trying to integrate some of those things that help us feel well. The 5 C's are really honoring the relationship, providing some content about what's going on and trying to be as objective as possible. And then we want to actually make a plan. And then check the story. Sometimes the story in our head is not accurate, and offer some compassion. So it's as if Bill was reading our minds. So I was working with a provider who every day was getting double booked right before lunch. And she was not happy about that. And she kept going to the front desk and saying, like, I don't mind if you double book me earlier in the day. I don't mind if you double book, but I need to eat my lunch. And so we talked about what's okay and what's not okay for her. What was okay, she felt like it was okay to be double booked. What didn't feel okay was doing it right before her lunch hour, right? What felt okay is asking. What didn't feel okay is doing it without checking in about, other patients or other needs that we're pressing, or offering some other help or support in an integrated care setting, right? Like, can a nurse take over something? Do we have a care manager that could take this off my plate so that I could help you with the workflow balance today? And so we created a little script. I do lots of help with scripts, and not scripts like RX, but scripts that we say so that we can be more compassionate. And so this was the script that she and I came up with. This is Allison is the name of the person she was going to go back and talk to. So first she just gave context. Allison, I really like working with you, and I like working here. We're a great team, and our work is really important. That's the context, right? Honor the relationship, start there. And then provide the content. What's going well? What's okay? What's not okay, right? That's the boundary. When you ask me to work through lunch, it makes me really grumpy and hangry all afternoon. I really need to eat and have a few minutes to re-energize during the lunch hour. And then you're asking for completion or a plan, right? Can we make a plan together to address this? Right? Whenever possible, we try to be collaborative. And then we're going to check the story that's in our head, and we're going to state it out loud for that person, because in my mind, it feels like breaks aren't very important or valued by you. And I'm sure that's not the case. And then a little bit of compassion. I look forward to finding a better solution. So I get lots of practice as a psychologist and communicator doing scripts like this. I know that some of you are looking at this right now and going, oh, Lordy, I don't know if I could have this kind of conversation. And some of you are like, I could do it. I might be more abrupt. So just an offering here of how we might approach someone around a boundary that is honoring of the relationship and also hopefully gets our needs met. I'll give you one more example, then I'm going to pause and I want to hear from all of you. So let's say you are asked to be on a committee. Before you even respond, I encourage you to do a little T-graph just like this, right? Of what's okay and what's not okay for you. And in fact, when I send the slides to Stephanie, I'll also send you this little boundary worksheet, because I find that it's really helpful to just have, if you're like me, like to write it down. So someone asks me to be on a committee, and I think, Catherine was talking before about this duality of like, I like doing some of the administrative stuff and it feels hard to balance with patient care. So what's okay? And this is unique for me. This is, I get to design this for myself. What's okay with me and not okay might be different for all of you. So what's okay? I like being asked. Thank you so much for thinking of me. You must think I have a unique skill set or something to offer that you asked me to be on this committee. Awesome. It's also okay to ask me if it's a good fit for me right now. It's okay to consider if this is the right season for me. And let me tell you what I mean by that. My son is a senior this year. And so in my family, we call it the year of Jack. If there's something that interferes with me celebrating his senior year, like the end of the wrestling season or a special awards night, or even just like visiting the school for conferences, it's a hard no for me. I don't want to miss things. Next year, ask me, for sure, ask me. But right now, my season, I might say no to like evening commitments or extra things, but I want to help another time. It's also okay to pay me for my time if you're asking me to do more work. and it's okay to block time on my schedule. What's not okay is to ask me to add this to the end of my day, or not providing me an end date. Hey, Amy, would you like to be part of this ERG group to talk about, talk with parents who are, raising kids, or sure. For how long? Oh, like until, 2027. No, thank you. I would like to have an end date that I can see in the near future, and it's not okay to make it required. Not okay to ask me to miss time with my family or friends, and it's definitely not okay to ask me to be a tokenized representation for a group of people. So this is an example of like my T-chart, what I might go through if I'm being asked to do something. All of you will have your own unique ways to do that. So just a couple of thoughts around boundary setting. I have a couple more examples here around boundaries and appointments with patients in terms of integration, and some other ideas that I hear from other providers in the field. But let me just pause for a minute. Thoughts, comments, questions? Skepticism, also welcome.
Definitely, I'm thinking about, for those of you who maybe, again, that sometimes it's not within your control, right? Again, when we think about social needs and that need to screen, and then that urgency to really connect folks to services or to another care team member, sometimes it doesn't feel always within your control, or there's, or who to talk to. And so I just wanted to call that out to say that it does sometimes feel like, well, where do we go, or how do we set some of that? And so curious if folks wanted to talk about, yeah, again, like when you said skepticism, Dr. Amy was like, I'm sure there's some of that in this group, considering, again, the networks and the systems in which you work. But just wanted to call out that maybe sometimes it doesn't seem possible.
If you're all like a lot of the providers that I work with, it feels like there's too much to do in an appointment, right? Yeah, I'm seeing lots of heads nod. And so how do we prioritize balancing the needs of the patient with your need to not be at work until 8 o'clock at night? Yeah, Catherine.
I think that it can be really hard because everything feels like an emergency. So one of the things that I preach to my team a lot is, just because it's their emergency doesn't make it our emergency. And we have to be the calm, cool, collective person, because if we're both freaking out, it's not going to end well. So like one of my boundaries I have is I always leave at 5. I leave on time. I always show up early, but I always leave on time. Unless it's a life or death situation, it can wait until morning. And that's just because that was the parameter I needed to not be burnt out or feel upset or angry that I had to stay. So I created a boundary within myself, and a chart note can wait till tomorrow, as long as it's not life or death.
Yeah, thanks for sharing. Absolutely. Does anybody else relate to that feeling of like, someone comes in and they have like 20 things on their list that they want to talk to you about, and you're like, I got like 10 minutes here and I'm already behind today. How do you triage that? Yeah, a team-based approach. I'll tell you what, one of the FPs that I work with. Oh, no, go ahead. You go ahead and share first, Bill, and then I'll share my idea.
I've just gotten really blunt with patients when they come in and, the nurse says they've got 7 things, saying, hey, I know you have a lot of things that you want to cover. We've got a limited amount of time. Let's prioritize it and have an appointment again in a few months, and we'll make sure to get you scheduled on the way out the door. One of the things, and I feel like I've got pretty good success with that, just in terms of how I present it and the space I hold emotionally with folks. And one of the areas of challenge I'm having is I've got a provider who feels like every time she tries to hold that boundary with a patient, the patient just gets really mad at her. And so she immediately spills over and, you know, gives the patient everything they want, so to speak, or the patient gets mad with them, and then that's a fractured relationship. So I don't know how to coach somebody to do what I've figured out how to do in this space.
Yeah.
I mean, I can give her the script,
Mm-hmm.
but I don't know how to help the script sound natural, warm, welcoming, inviting, and firm.
Okay, first of all, I love what you're saying, right? Because we actually can balance firm and warm, and all of you will have a different way of doing that. I'm hearing a good friend of mine who's an FP. When she walks into the room, similarly to Bill, she says, so we have about 15 minutes. And she looks at a clock and she says, by my clock, that's going to be at 1:05. And so tell me what your priorities are today. And they have their list of 7 things, right? And she says, and I think sometimes, like Catherine just said, everything feels like it's on fire, but that's where you also get to lean into your expertise as well. You have an expertise and the patient has their own lived experience of what feels important to them. And letting them know, like, based on what I'm seeing, this is what I might prioritize today on your list, whether it's said out loud or on a piece of paper or whatnot. And you tell me what one of your priorities are, and we'll see if we can't meet a couple of those priorities today. And then the rest we'll have to save for another time. I also hear other colleagues of yours say things like, there's some things that we can handle through blood work and in the portal, that somebody else can manage in integrated care settings, and some things that I need to do with you right here in this moment, as your provider. And that can be a really nice balance as well. I also, oh yeah, I love Jen saying it, right? And I want to reiterate, the patient, it seems like they're mad at you, right? And it's hard not to internalize that. The patient's mad at the system. And I think you can actually align with them and say, me too. I wish we had more time. And sometimes that's the most validating thing in the room to say, I'm with you. I wish we had a whole hour as well. You can imagine if I ran that late with you, no other patients would be able to be seen today. And everybody has the same needs that you have today in terms of wanting to see me, wanting to get in. The physical need might not be the same, obviously, but they all have a desire to see me today. And so we have to limit the time, and we will make sure we get you scheduled on the way out. We're both frustrated with the lack of time. I think sometimes naming the fear that's in the room, right? Like, we're going to run out of time, or, you're not going to get to all of my things, and aligning with them and validating, we both feel that way. And then both Nicole and Jen are saying, people have their feelings, right? And often they're not mad at you, they're mad at the system, and rightly so. Yeah. Before I'm seeing the reminder from Stephanie to just be on time. I'll offer a couple of things, and I'll make sure that you get these things, but we kind of mentioned acknowledge time limits, acknowledge your patient's need and other patients' needs as well. Allow them to go first and prioritize a couple things, and then collaborate on the other priorities that are there. Decide what needs could be met outside the appointment by other folks who are on your team. Follow up is needed. And one thing I always try to remind people in primary care is you have, my hope is, right, lots of opportunities for seeing this person or people on your team to see this person. That's 100 small doses in primary care. Unlike specialty health or sometimes acute care, ER, for instance, we have lots of opportunities to work with patients. So we won't get through everything at every visit. We're going to do the very best we can with the time that we have in those moments. And these are just other ideas that folks have shared with me over the years. Setting limits on patient portals. I had a pediatrician tell me one time that they didn't realize when they set up their EHR that it was like like you could write paragraphs, and people were like adding like Word docs with their whole histories in there. And then the nurse managers were feeling like they had to like triage all of this. So they put like a 200 word limit, like, tell me what's going on. Looking at workflow, administrative tasks, and pace. We talked a bit about if it's possible. A lot of folks are like, how do I hire other things out, a scribe, an errand runner, even someone to help me personally? Job sharing is really common, as is locum tenens, not possible for everybody, but again, lots of ideas that folks have shared with me over the years. Leaving work at work. Catherine just mentioned that. Having a workplace buddy. Turns out that if you have another person at your site that's looking out for you, hey, Stephanie, did you use the restroom today? Have you drank water? Have you taken time off? Or why are you still here? Those charts can wait until tomorrow. That we tend to take better care of other people and not ourselves. So there's a lot of research on workforce wellness that when we are assigned or have a workplace buddy, we are a little bit less in the space of overwhelm. If you are a leader, relational leadership engagement, which could be a whole other lunch workshop, but just being in relationship and not judging ourselves by other people's standards. Again, different people have different seasons in their life. Some of you are like, I don't mind staying until 7 o'clock because then when I'm done, and I don't have to worry about a big pile in the morning. That's okay. That's your unique boundary. And everybody's a little bit different and not holding ourselves to other standards. If possible, investing in mentorship or coaching, if your place of work or your clinic or organization offers ERGs, especially if there are affinity groups that are there. Affinity groups can be really powerful ways to feel like you're in community. But those are just some of the ideas in order to really find that some of those boundaries. And I'll send you the little handout on boundary homework because I know we all have to practice doing that more and doing that in ways that feel really authentic to our nervous systems. Okay. Oh, Catherine, I love that. She said in the chat, my pharmacist and I take walks together to force ourselves outside of the clinic and away from the screen. Yeah, lovely. Well, I'll hand it back over to you, Stephanie. I feel like all medical spaces, we all like engage in what I call speed dating.
Yeah.
And so I hope today felt helpful. Thank you all for your time.
Thank you, Dr. Amy, for coming to share. And again, just bringing like humanity, community into this space. Again, we recognize that, again, that duality, I think, is so we're like, we love our work and, right? And so it's nice to be able to share that space, have those practical tools. And in terms of creating affinity space, again, this is a webinar series. And so we would love to hear from you what other opportunities or just spaces for discussion you'd like us to bring to the space. So I did a rather quick poll. So before you hop off, you could give me another minute and just go ahead and let us know what other conversations of topic you'd like to discuss again around workforce and team-based care and those pressures of really integrating all of these disciplines and all of these tasks into that primary care setting. It would really help us in finding content, resources, subject matter experts like Dr. Amy to bring to you in our next couple of webinars that we have planned. I'm going to go ahead and share my screen really quickly so that you can see when those other ones are coming up. And we'll make sure that folks have, again, copies to slides and the tools that Dr. Amy shared, as well as upcoming webinar dates if you want to join us. You may already be plugged into OPCA peer group spaces. So there we have medical director groups, behavioral health peer groups, CHW peer groups. Joanna is our kind of peer group person. And so if you have any questions about it, I'm not in a peer group and I'd like to reach out to her. We can also put our peer group page on our follow-up email so that you can stay connected. And Dr. Amy also mentioned the Connected Collabs that she hosts. If that's something of interest, please reach out to her. And again, happy to put this on an email so that you stay connected, continue to create community, and identify practical solutions to really support your day-to-day work. And again, thank you so much for being here during your lunchtime. Thank you for the work that you do. Thank you for all that you balance. We really appreciate you spending time, and we hope that you're able to take a little bit of something away with you today, even if it's just some you time. When you jump off our webinar, you'll see a quick evaluation survey. Again, we'd love to learn what's working, what's not working, what you'd like for us to do differently as you engage, because your time is valuable to us. And again, we're here to serve your needs. So once you're done with that poll, feel free to hop off. And if you have another minute to do a quick survey, we'd really appreciate that as well. But again, thank you all. And again, thank you, Dr. Amy, for starting us off. It's been a pleasure to have you here and to learn from you. Thank you.
My pleasure.
All right, everyone, have a good rest of your day. Take care. Right. And Dr. Amy, happy to share kind of those polling questions with you and that evaluation as well.
You bet. And I am emailing you right now the PDF of the slides and the boundary worksheet. It's just kind of a fun little.
Thank you. That's a great one. Yeah.
Yeah.
And these things feel again like practical, like things you can do for yourself and help you set that tone and practice for yourself. So thanks for getting us started. And again, really appreciate the way you
Absolutely.
facilitate and share content. It was fun and a great place to connect.
Oh, good. Yeah. I always want people to have actionable tools.
Yeah. Yeah. And then we will be in discussion and see how other ways we're able to partner again, bring folks to some of the areas of your work, and then invite you to other spaces as well that we have here with our membership. I think there's definitely a place for collaboration. As you mentioned in your chart, right? Like we're really in this need where we need to care for ourselves and create community. So again, thank you so much.
Absolutely. Thanks for having me. Have a good lunch hour.
You too. Bye-bye.
Bye.